but you can put notes up here.
So we have. Jij hebt de tijd wel bij je, of niet? Okay, very much welcome to everyone here at this symposium called Improved and Differentiated TB Program Planning through More Effective Use of Various Sources of Subnational Data. My name is Lucie Blok. I'm a senior advisor at KIT, Royal Tropical Institute, and I'm co-chairing together with
I'm Suvanand Sahu. I work in the Stop TB Partnership in Geneva as the Deputy Executive Director.
Okay, so the purpose of this this symposium has to do with the fact that we are all very much aware that we are still far away from achieving the 90-90-90 targets that we have set for ourselves as a global community. And we also know that the barriers and the gaps are quite different across different countries, but also within countries, and that there is a very much important need for prioritization of the actions and targeting of actions, and really understanding the specific needs of different population groups as well as different parts of countries. And for that, there is still a possibility to make much better use of available data, but we also have seen that there are some very exciting examples of countries that have started to make use of more various variety of data sources. So as the program is quite tight, I don't want to spend too much time, and I would like to invite the first speaker, which is Mirjam Bakker. She's a senior advisor, epidemiologist and advisor on disease control and health systems at my institute, also at KIT in Amsterdam. And I give the floor to you.
Thank you, Lucie Blok. Good morning. No, not good morning. Good afternoon, everybody. My name is Mirjam Bakker, as Lucie already introduced me, working for the Royal Tropical Institute as an epidemiologist indeed. And I will present our approach, which we have called the match approach, which we developed specifically for NTPs for them to use their data, their subnational data, for planning purposes. This is not done by myself, but with a whole team of colleagues, which are mentioned on the slide, and done also in collaboration with the Stop TB, and it was also partly funded by the Global Fund. Let me see. And I will use some examples from Bangladesh, which up front I would like to acknowledge there, that they agreed to share these maps for learning purposes. Let me see if I can, How can this... Where do I point to?
Where do you have to...
All the way there? Okay, thank you. Okay, so anyway, this slide has already been covered by Lucie Blok. That we have to do things differently to reach our 90-90-90 goals, and that there are still possibilities in using existing data to learn more about local epidemics within countries, understand challenges and the gaps better, to develop locally effective plans of action. And yeah, like Lucie said, things are not the same within a country. There are differences within a country that need different approaches to tackle. Yes. So like I said, subnational data is really powerful. Analysis of subnational data. It will really help you to understand your local epidemic better. Where in a country are people with TB being missed? Who are the missed people with TB? What do we know about them? What data do we have available to have a better idea of these to answer these questions? And then why are they being missed? So what do we know about the local TB response within a country? And after we have gone through all these questions, what are the possibilities to intervene? Which context-specific interventions are needed to find those individuals with TB? So really the how question. Like I said, we developed an approach. We call it MATCH, which stands for Mapping and Analysis for Tailored Disease Control and Health System Strengthening. And we applied it for TB programs. And it all starts with identifying existing sources of data. There are various sources of data in country that are often underutilized and have a real potential to provide information that is often not being seen yet. After identifying these sources, of course, they have to be linked in such a way that they can be used. And since mapping is a key element of our approach, they also have to be geocoded, that the data can be mapped. After the more data management part, there's the mapping, of course, the analysis, and then the definition of the evidence-based targeted interventions. And we see it really as something that should have a routinely component in it. It's not a one-off step. It should be something that ideally an NTP could do on a more routine basis if they have proper access to their data and proper availability in a way that it can be used to do this type of analysis. So the aim of the approach is really to, like I said, to capitalize on multiple readily available, often underutilized data sources at national, but specifically at subnational level, and apply a set of analytical frameworks leading to differentiated action plans. And these data sources can be from, of course, the NTP, one of the most important ones, but also various other data sources, which I'll mention in the next slide. And apart from using available data sources, we are also really focusing on using open source software. And Quantum GIS is one of the open source GIS software programs that we are using for this. So possible data sources that are available, of course the NTP have their own data, which of course they are already using in their monitoring purposes. But there's also the laboratory results, tests being done, results, treatment outcome, TB HIV activities, and then of course there are other surveys being done like TB prevalence estimates, sometimes give regional estimates, inventory study results, different types of studies done within the NTP. But there are also population surveys often being done, the DHS, the Demographic and Health Surveys. They give really informative information on possible risk factors. Sometimes there's an HIV prevalence survey data providing data on the HIV prevalence, which is very informative. DHS2 or HMIS data on other comorbidities. Anyway, there are lots of different types of sources that can be used. Health system data, what do we know about the services provided? And then, of course, there's the spatial data. So you need, of course, the map of the administrative boundaries of the subnational level that can be used in a country. So we developed this analytical framework, but we came up with 5 steps, which is not a blueprint, and we already realized when implementing it or when applying it in different countries that different countries have different sets of data and also follow different approaches, of course. But this is a general 5 steps that we identified, and it all starts with mapping out your case notification rates. What does it tell us if you show your case notification rates on a map and go to district or even lower level of granularity? So what do you see in space, but also over time? Then what do you know about the local burden? How do the case notification rates match to the local burden? What do we know about the local burden? For example, through other mapping risk factors of TB, mapping the regional TB prevalence estimates, where are the key populations distributed? What do we know about the burden among certain key populations? How does that inform us about the burden of TB? And how does that then relate to the case notification rates, and where do you see gaps? So once we have a better understanding of where the possible gaps are with regard to missed TB cases, it's then also important to find out why are we missing those patients, and who are they? And one of the things then to add is also to look at the diagnostic coverage. What are the efforts that the TB program is putting into it to find those TB patients? So when we look at testing rates, for example, how many people are being tested in a certain area, and how does that relate to the case notification rate, and how much variation do you see? And once all that really comes together and there's a better understanding of all the differences within the country, you then want also to understand what's the TB, the local response to it. So what is the TB care program doing? So what do we know about access to care, and what do we know about the quality of the program? And we can look, for example, even at the EQA results, the external quality assurance of the laboratory data, but also on the treatment success rates. So in April this year, we had a workshop with 10 Asian countries, which was co-organized with the Stop TB and the WHO. And there were 10 Asian countries to which we presented this approach, and we beforehand worked on their data, so that at that workshop they could all simultaneously work on their own data and follow the steps and get a bit of a feeling, what does it mean if you go through these steps, and what can you learn from going through these steps, and how valuable is it to them? So Bangladesh was one of the countries being present there, and even after the workshop, this initial workshop in April, they had another workshop in August where they had a 5-day So where they had a 5-day in-depth of going through these steps, and I want to show you some of the results of this workshop where they went through these steps. So the first map, what you can see is where it really all starts with, the case notification rate at the district level. This is the one for 2015, and you see already lots of variation. I don't know if I can point to it, but you see areas with high notification rate, and you see areas with low notification rate. Sorry. Yes. Maybe I shouldn't point to it. Yes. Okay. The case notification rates. I think what key is to get from this map is that once you look at your case notification rates subnationally, you see areas with high notification rates, which we all of course know, and areas with low notification rates. And what is interesting to see, where do districts deviate from, for example, their neighbors? Where do we see districts with a low notification rate that are surrounded by districts with high notification rates? And then NTPs can wonder, why is this? Why do we see this discrepancy? So what we do is some spatial analysis with this data to see whether there are spatial trends, whether there are clusters, for example, and then you see in the next map, the cluster map, where you see indeed some significant hotspots, so districts combined that have high notification rates and low notification rates, the cold spots in the dark blue. But what is even more interesting is those districts that deviate from their neighbors, and the lighter blue ones are the ones that have low notification rates, but the neighbors are much higher. And then you wonder why, what's happening over there? Why are they why do they not find the same case notification rates as the neighbors? So you can learn from it. And maybe there's a valid reason. Maybe the burden is indeed lower, but maybe the efforts are less. So next step is, for example, to put on top of this map the laboratory results. And here you see in the first map the testing rates. So how many people are being tested per 100,000 population? And again, you see a large variation, and you see Here, for example, a large area with low notifications and also much lower testing rates compared to, for example, here and here. Testing rates are much higher. And then next to it you see a map where we combine the testing rates and the positivity results. So how many of those tested are being positive? As that also tells you something. If the test rates show low positivity rate, they may test people that are, it can tell you something about who they are testing, but it could also tell you something about the poor sensitivity of the test that they're using, so also about the quality of testing. If has a high positivity rate, you can maybe expect that they only test those that are coming to the health facilities and are already very ill. So access to healthcare is another layer that can add to it. This one shows the microscope facility density, tells you something about access, how many facilities are there to be accessed over the population. And treatment success rate is an example of what do we know of the pathway to care. Where is the program functioning better than at other places? This was just an example of a few maps that the Bangladesh team was preparing. They also added other data sources to it. But at the end of the workshop that the Bangladesh team was having in August, they at least already identified a couple of next steps from the whole analysis that they did. So, for example, the yellow area identified it was identified as a cold spot. So, a combination of districts with low case notification rates. And they also noticed that there was a low diagnostic coverage over there. So, not compared to the other districts, not much testing was going on. They also noticed that positivity rate was low. So, maybe also said something about the quality of the diagnosis being performed, and that immediately already for them initiated several possible interventions they considered. At least the first step was that they were going to do a supervision visit to this area to find out what's going on, and whether, for example, more active case finding should be initiated in this area. So it already led to possible follow-up actions for the NTP. Yes. No. And that's, yeah, well, anyway, these are my two slides, my two final slides. Like I said, it's nice to do all these analyses, and I only showed part of the analysis that can be done. But of course, at the end, it all should lead to more tailored TB program planning. And then the question is, which gaps should be prioritized, and which interventions do we know already can be very successful or unsuccessful in this area? And these are usually context specific. And then, of course, you should look at the whole pathway of care from infection to treatment. Where can we intervene, and what is needed based on the analysis and based on the context-specific knowledge that the program has. And then finally, my last slide again, showing the match approach. But we can also leave it with this if my time is finished.
Yes, it works again. Thank you very much, Miriam, and for this presentation and for the overview of this approach, and with an example of how it can be used, and we will see a few more examples also as we continue. Given the time, and also in order to give the other speakers enough time, I propose that we do the questions at the very end. So we continue with the next presentation.
Yes, so we will have time at the end to have questions and comments. The next presentation, we go to Vietnam, a high burden country, and Dr. Nguyen Hoa is the secretary in the National TB program, also the coordinator of the Global Fund grant in Vietnam. Dr. Hoa, you have 10 minutes.
Yeah, thank you very much for the introduction. Good afternoon, everyone. On behalf of Vietnam NTP, I would like to present the different TB planning in Vietnam using subnational data, using the approach that Baker Mirizam have just presented. So, in the conflict of interest, in my content of presentation, I will present on the TB epidemiology in Vietnam, the use of subnational data in TB planning, and the data source, data analysis, and the conclusion. So for the TB epidemiology in Vietnam, this is sorry for the typing here. This is the Vietnam is the rank 15 among the 30 TB high burden country, with the incidence of about 130,000 TB case per year. And Vietnam also ranked 15 among 30 countries with the high burden of MDR TB. So you can see here, this is Vietnam, this is in the overlap between the TB and the MDR TB. You also could see the map of Vietnam. Vietnam is a long, very long country, with the TB notification is very different between the area. And the TB is the burden of TB is more higher in the south of Vietnam compared to the north of Vietnam. So it's interesting that in the south Vietnam is the border with the Cambodia, and the epidemiology of the TB in Vietnam in the south is similar to the Cambodia. And in the north it's the border with the Laos and Laopedia, and the epidemiology in the north of Vietnam is quite similar to the epidemiology in Laopedia. So for the differential TB planning in Vietnam using subnational data, we have to identify source of data using standardized data template to extract and collect data. And we have a capacity building to collect, analyze it, and interpret the subnational and disaggregated data for strategic use. So we send staff to the Bangkok workshop in April to learn about the analysis and analyzing the subnational data and identifying the main programmatic gap and challenges in order to plan appropriate local intervention. So for the subnational data in the national TB program, you can see here we have the VTMAT. This is the case reporting. So every single TB cases have enter data in here with 90% of the coverage aggregated data. The aggregated data is 100%. In the K-based data, it's 86% in last year, and this year is coming to 90%. And we have ETB manager for the MDR-TB. We have lab data is also in the VTMAT. We have active case finding in prison is also in the VTMAT. The public-private mixed program. This is the separate data reported from the province. And childhood TB program is integrated to the VTMAT. And besides that, we have a lot of the research project. We have data. Example in here is the first TB prevalence survey conducted in the year 2006-2007, and currently we conduct the second TB prevalence survey in the year 2017. So we have a TB notification data in the VTMAT, TB HIV activity, TB treatment outcome data, TB laboratory data, and also the EQA results. So for the national survey and statistics, we have a risk factor and comorbidity data from the demographic health surveys and health coverage data. We have 63 provinces and more than 700 districts, and in each district we have TB units which have microscopy. We have a location and functionality of TB diagnostic and treatment facility. So in each district in the nationwide, we have one treatment facility and one is the microscopy unit. But the population in the districts is different between the district and districts and the population data. Sorry. So for the local TB epidemic, in the first step is we study the case notification rate over space and time. So it's to choose the case notification rate is for the routine collecting from the program, and this data have a check and with the quality of the data. So this is you can see this is the distribution of the case notification is very different between the north and the south. It's very low in the north of Vietnam. Here is in the mountainous area, and this is for the Red River area is bigger, and this is the most high in the south of Vietnam. Is the border with the Cambodia. So for the many years, the notification rate is very consistent between the province and the districts. And this is we see is how is the distribution of notification rate, subnationality, and how consistent over time and across the geographic area, and it's very consistent over year. Identify area which deviate from the expected case notification rate. So for the expected case notification rate, we use technique is for the adding the surround of the province and district notification rate, and take the average for the expected case notification rate for the province and each province and districts, and comparison the real case notification rate with the expected. So this is here is the population and case notification rate for the year 2016. So this is for the population. This is for the number of the population. This is more crowded in the near the river, in the Red River in the north, and the Mekong River in the south. And it's low density and low population in the mountainous area and in the middle of Vietnam, in the center of Vietnam. So it's quite you can see here is quite similar with the number of TB cases and the population. So this slide shows you this is a high and low notification and its particular pattern. This is the comparison between the expected case notification compared to the real case notification. So this is quite consistent with the correlation is about 0.6, which one is a perfect correlation. So in here this is the comparison with the notification reported with the expected notification is calculated by the surrounded districts and province. So this is the high spot here is in the south Vietnam, and low cluster here, low cluster in the mountainous area. So we also comparison with the result of the TB prevalence survey in the 2006-2007. So TB prevalence is also lower in the mountainous area compared to the urban and rural area. So notification rate compared to the notification rate of the neighboring districts and the high density of the population in the south. We can also see in the next slide is also the high HIV prevalence in the south, and we have many migrants in the south, internal labor migration, especially in the Ho Chi Minh City. So in this slide, so this is the accumulated HIV affected for the year 2015. So we can see that this is the many HIV number of HIV patients in the South Vietnam, and it's also high in the area which is the high of the notification rate. However, in some place of the low notification rate, it's also a high number of the HIV infected cases. So what's the relation between the notification rates, the estimate burden, and the program effort? So we also see is how much the notification rates can be explained by the local program efforts. So this is a graph, so it's a national data. So we do this every year, long time ago, and you can see that is a number here is the number of the suspect screen. It's increasing from the year 2007 to 2015, and this is the number of the case. Number of smear positive cases detected is quite stable during the year 2007-2015. So the positivity rate, this is a decrease from the 9.4% in the year 2007 to the 7.4% in the 2015. So in the year 2015, we have to make the sputum examination for nearly 900, more than 800,000 suspect cases, and detected about 60,000 of the smear positive TB cases. But this is the number in the national data. So we need to test this for the possible indicator here for the province and district level and put in the map to see how it's different. So this is the testing rate and case notification rate in the year 2016. So it's also seen in the previous slide in the mountainous area here. This is the very low of the case notification rate, but since we have also some province have a low test rate, and it's also low test rate in this area. So this province we can, if we can screen more and testing more, maybe we can detect more TB cases in this year. So it's similar. We also compare analysis for the test rate and the test results. It's the positivity among the test person with test, and some province here. This is with the low notification rate. This is the positive rate is also low. So in conclusion, data used for planning, finding missing case and finding TB earlier. We could we have pushed the intensive and active case finding among the increasingly difficult to risk group for the contact investigation for diagnosis of TB in children and in adult contact. TB screening among the people living with AIDS, example for some province and districts where have a high HIV situation but low notification of TB. Expand TB screening covering all prisoners in addition to strengthening routine zone TB HIV service. Intensive case finding in the remote population and to screening in the elderly and urban poor, and among the more case finding among the men aged 25 to 45, using the more sensitivity screening methods. So for conclusion, is the subnational data analysis will assist to know the local TB epidemic, where TBK missed and who are the missing TBK, and understand the local TB response, why K missed, and which context-specific intervention are needed to find those individual with TB. And Vietnam plan to apply the subnational data analysis for reviewing evaluation of TB performance and identify the issue needing further investigation for modeling, planning, and decision making. And resources allocation. Yeah. And Thank you very much for your attention. I'm sorry for the, yeah. So for the acknowledgement, yeah, thank you.
Thank you, Dr. Hua. So you nicely brought out this match approach application in your country, and very interesting maps, north and south, and how different it is. And
Yeah.
so we will discuss more on it during the questions. We now move to the next presenter.
Yes, so thank you. The next presenter is Dr. Masini from Kenya. He used to be the NTP manager, and a lot of what he's going to present is also stemming from that time, even though he already moved on to be the technical advisor for WHO, but still in Kenya. So he's still using all of this information. The floor is yours.
Thank you. As I wait to... So my presentation is on finding missing TB cases in Kenya using subnational data to be able to identify geographic areas and risk populations for which we can have targeted interventions. Kenya is a high TB and HIV burden country. For TB, it appears among the 30 high burden for TB, MDR TB, and TB HIV. Okay. So I would like to acknowledge various institutions and persons who assisted us in thinking through this process. And as I indicated earlier, this is the outline of the presentation. And I think I've covered that. So for the last 7 years, there's been a decline in the overall TB cases that are notified in Kenya. And before 2015, the question was that does this decline represent the actual burden? Does it represent a falling incidence? That answer became apparent in 2016 when the result of the prevalence survey were released, and it showed that indeed the burden of tuberculosis was much higher than we previously thought. And if you constructed a care cascade based on the results of the prevalence survey, then you would find that the treatment coverage is probably less than half of the incident cases that occur. And I think, as has been presented by my colleague from Vietnam and Mirjam, is that in my country, the subnational level is comprised of 47 county governments or regions, 47 regions called counties. The burden of tuberculosis that is notified and reported differs variedly across the counties. So as raised before, if counties that are neighboring each other have such vast differences in burden of disease reported, it begs questions that does it represent the actual expected disease? Okay, so from there we did various activities to be able to understand what would be the underlying risk factors. So from the notification data, from the prevalence survey, from the patient pathway analysis, and I'll review some of those. From notification data, and indeed from the work that has been going on in Kenya, a lot of success in TB-HIV collaboration. And on average, nationally, the TB-HIV co-infection rate is going down. But if you look at the various counties, you will find that there are counties which are neighboring each other, have a same HIV prevalence, background HIV prevalence, but have difference in case notification rates. So could there be, it suggests that there are some counties who are not finding all people with HIV who have HIV-associated TB, and will probably require deployment of different package of interventions in them. In addition, the prevalence survey showed that a vast majority of the cases are HIV negative. So showing three things. One, that the interventions for control of TB among people living with HIV have largely worked. And two, is that the burden of the disease has moved on to largely to people who are HIV uninfected. So that means we have to look for these people. Where are they? And the survey further showed, if you look, gender is a key factor in TB epidemic in Kenya. So gender and age. And I hope this works. So this is for males. So the burden in males is double that in females. But significantly is that the missed cases in males are much more, and especially in these age groups. Then secondly, for females, the case detection gap is fairly minimal across the age groups especially, but only in the ones above 65 years. So this has helped us to identify those key groups that would require our intervention. Then urban and rural, again, a higher burden, more double than in the urban than it is in the rural, and the case notification data also validates this, but also helped. We do not routinely collect data on comorbidities, especially those related to NCDs or non-communicable disease. But from work that is going on suggests that this is a key factor, and that has made us start TB diabetes collaborative activities in selected counties that have a high burden of diabetes. Poverty, there's really a non-correlation between poverty and TB, and from the work of the patient pathway analysis, we were able to further characterize that there are more barriers for people of lower socio-economic background in accessing TB services. And therefore, the NTP, the government, the Ministry of Health must be able to work on how do we work in poverty reduction and economic development strategies. So in view of this, what do we know also about the local control TB efforts? What is currently being done? A lot of deployment of technology, rapid diagnostic test, Xpert, and of course, microscopy has been existing. And this slide, I think, has also been showed in context, I think, what Miriam presented before and my colleague from Vietnam, where one, you have counties which have a high burden of disease, neighboring counties, low burden of disease, but the positivity and the testing rates and the positivity rates markedly vary, probably suggesting that it's not just about the deployment of the technology, but it's also about how do each of those counties work to develop deployment packages specific for them that can be able to navigate the health system issues, healthcare worker, the clinical needs, the patient pathway, to be able to ensure that the Gene Xpert or any other diagnostic technology that's put is actually effective in providing access to the services. Again, from the patient pathway analysis, is that patients initiate care at really in their own different ways, in different sectors, private, informal sector. But these sectors, the deployment of diagnosis is not aligned to the actual care seeking. Huge variations between the different counties in terms of where the patients seek care or where they initiate diagnosis and where there's actual diagnosis, where there's availability of actual diagnosis. But also in some counties, vast majority of them seek in informal private sector, which not a lot of collaboration with the NTPs. So it means that there has to be a different PPM packages for such counties. So in view of this, what is being done in Kenya? So several things. And one is that the National Strategic Plan provides a differentiated approach to strategies. Really provides counties in three main groups with different interventions to be done there. But also a lot of emphasis that is ongoing, and I think it was presented in the WHO Symposium, on capacity building of the counties to be able to use the subnational data for local planning and programming. But another key thing is this, and I don't know about your countries, but in my country, there's scarcity of data about the screening, what goes on in screening. So the number of people screened for TB, how many were positive. So when you are constructing the care cascade, it becomes very difficult to bring about interventions that will be able, you don't know where the gaps is. So this is a way to get these numbers. So probably from next year, we'll be able to, for each county, for each facility, we can be able to demonstrate how many people have been screened, how many are positive, and provide recommendations. But also TBDM, of course, interventions targeting men, as you've seen, engaging informal providers and chemists. But many now of the partners applying for grants, like the current TB Reach grant focusing on pediatric TB, are actually using this information. So when they apply for a specific county to work in a specific county, it depends on the needs of that particular county from the information that is available. And lastly is that in the upcoming grants for Global Fund, which has been awarded under the catalytic component of finding missed cases, we have established a county innovation challenge borrowed from, this is a picture that's borrowed from Reproductive Neonatal Maternal Health Challenge Fund, in which counties, because of the different needs and context, under UK aid, come up with interventions and apply for funds. It's a performance-based grant. So for TB, we are also doing the same from next year. So each of the counties come up with specific activities, cognizant of their peculiar or their different health systems and all that, but it's based on performance, and tell us how they will be able to get the cases, and then they get supported, and that is tracked. I think that is the last slide. Thank you very much.
Thank you very much, Dr. Massini, for a very nice example of use of very different types of data in trying to understand what the situation is and also what the specific gaps are across the country and across different population groups. And so thank you for, and also use of different methods for analyzing these data and bringing that all together. Thank you.
So we heard now so far 3 countries, Bangladesh, Vietnam, Kenya. Now we deep dive further. We go to a mega city, Mumbai in India. And we have here Shibu Vijayan, who is the director of TB HIV in the PATH India office. Shibu, the floor is yours, 10 minutes.
Yep. Thank you, Dr. Sahu, for the introduction. So I'm just, this is unlike the presentation you heard earlier. I'm going to focus on how we actually designed a project to engage the private sector and how we utilize the data for the provider behavior change. And what are the, what are the way forward, thinking in collaboration with the government, what are we doing? So the context, the Mumbai, I'll discuss about like how Mumbai looks like. What we did for mapping and understanding the provider universe and the model of service delivery and notification data, how it actually varies between public and the private, and provider behavior change analysis, and a little bit on prescription audit because that's also a quality indicator to measure and way forward. Mumbai is a mega city, as Dr. Sahu mentioned. There's 12.5 million population. There are 24 wards. Mumbai Corporation has actually graded the wards based on the TB high risk, medium risk, and low risk. This is based on the notification of the public data. There is no private information here. Embedded here. This is actually later. We use this as a map to actually prioritize our interventions. High incidence of MDR-TB and TB and MDR-TB. Then there is also there was a pathway study done which also demonstrated 61 days of TB diagnosis delay, as well as 70% of the patients actually going to the private sector and to the informal sector. So we designed this project with the key objectives of early diagnosis, increasing case notification, and we also brought in the quality component by elevating the microbiological confirmation, and also treatment part, the standard of TB care we used as a quality measure, and adherence support, which is kind of a black spot in the black hole in the private sector where there is no system to actually track the patient. So we also tried to build in systems to sanitize that part. So the first activity, what we have done is a mapping. It is, it's not a rocket science. It's like just a listing of doctors in 15 geography in high TB burden wards in Mumbai by walking through the streets of Mumbai slums as well as Mumbai roads, and actually capturing information as displayed in the display board. In the hospitals, we went inside and collected information specifically about the doctors, but otherwise it's all actually captured information as from the display board. And we could found that actually if you look at this thing, the base of the pyramid is largely informal and the Ayush doctors. Ayush doctors are Ayurveda, Unani, Siddha and homeopathy doctors. So they form the base of the Mumbai service delivery. And there are chemists, roughly around 3,500. 1,000 odd labs, MBBS doctors. These are the basic qualified doctors in Indian system in India who are actually licensed for medical practice. Though they are, relatively high in number in Mumbai specifically, their presence as a first point of contact or as a general practitioner is very low. They support mainly consultants in the hospital. So their presence is kind of not so relevant in the TB context. MDs and the chest physicians are at the major service provider of TB. Diagnosis and treatment initiation happens at the MDs and chest physician level. Ayush provider see a lot of presumptive TB cases, but they don't initiate treatment. That they only refer it. And also we kind of understood what are the dynamics in the Mumbai. What are the existing private health system. So we also understood that the formal providers are, as I said, 76% of the informal providers are actually treating presumptive cases. That doesn't mean that they're treating TB. They are actually catering to chest conditions. Chest X-ray and the blood test was one of the most preferred diagnostic for anything, for approaching any lung health situation. 80% of the providers do not prescribe any diagnostic test. And we also found that there are actually provider network. Let's say if I am an informal doctor, I have a buddy doctor to refer, and buddy doctor pretty much remains the same. So we map that, that actually existing network. And there are also networking with the facilities, like, okay, I have a preference to the particular lab for X-ray. I have preference for particular lab for blood test, because either I am an entrepreneur because I have a share and stake in that, or there are actually existing transnational relationship between. So we map that, and also we also did a sub-analysis with how the slum population and the provider population varies, actually provider ratio varies. This was actually important to design the model and also tweak the model based on the provider presence between the wards. We cannot have a straight jacketed strategy in a high slum ward where the informal provider population is high. So we need to actually, there are occasions we need to create health system there. We need to bring in the chest physicians into the informal provider clinic to actually cater. So this analysis helped us in actually having a ward-based strategy and focus on hub facilities where the doctors, the formal doctors are sitting, and also identifying the TB aggregators. So we actually did, after doing the initial situation analysis, we also captured information from the chemist. We asked them, like, who are the champion TB prescribers in this particular locality. So from that we got a champion list. We actually reached out to the NTP, and NTP also gave us a champion list. So the initial focus was on the champion TB doctors, or TB aggregators. So we prepared a provider prioritization criteria where it actually practicing in slums. We also know that slums are actually TB engines. And also we looked at the daily OPD of more than 20 patients, so that we kind of cover a reasonable population. Not actively so initially we actually, those who are actually participating in the RNDCP schemes, those who are inclined to the quality schemes, we were not actually aggressively engaging because they are already quality service providers. Later when the project actually matured, they also came into our board. And those doctors who already have a buddy chest physician and systems are already well functioning, we prioritize that for initial engagement. Later we actually loosened our criteria. So we reached out to almost 90% of the mapped Ayush doctors. That reached out means we reached out and actually give the message, okay, there is something happening, are you interested? We also captured information about the OPD load, how many patients they are seeing. And initial when we thought about the model, we are expecting around 15 to 20% of the overall provider universe to be actively engaged at any point in time to get a estimated number of TB patients. So that was our initial idea. And we also track the provider behavior by looking at their service utilization. So what we did is essentially we networked create a network of private facilities within the private. So there was no public touch points at that moment, but now we are actually integrating with the public systems. So we build the service delivery system for the providers and support system for the beneficiaries. Everything, so the entire thing is actually ICT connected through electronic vouchers and electronic reporting mechanisms. What we didn't have is the electronic report generation mechanism. Let's say if I am a doctor treating 50 patients, I don't have visibility about what that, through an application, through a mobile application, I don't have visibility of what these patients looks like, how many patients I notified in a particular month. That we have to manually do it from the project side and give it to them. But having said that, we are working on an application which is Government of India is also collaborating with us for existing NICSHAC to have that intelligence to actually generate patient-wise reports, provider-wise reports, so that the provider will have hang of like how many patients I am treating, how many got cleared, how many are microbiologically detected, where am I standing in this entire universe of doctors in Mumbai in a particular geography. Am I ranked 1 as a champion doctor? Am I ranked 10th? Something like that, as we are expecting that it will soon come. It is in the process of development. So coming back to this particular map, we also track a provider actually engaged, how many of them are engaged, how many of them are actually active at any point in time. So if you look at the formal providers, 30% of the engaged formal providers are actually active at any point in time. Similarly, 20% of the, when I say activities, they have to do some referral, they have to prescribe some TB tests, or they have to diagnose. That is the activity. So this also helped us in actually looking at and prioritization and making them more active. Are we missing out champion doctors? So this analysis was important in that, taking the decision. And a little bit about how this impacted. So if you look at this, when the project coverage expanded, we could actually bump up the notification to an extent of 40% increase. So Mumbai, already the health system, there is an efficient public health system, already actually trained and sensitized the private system. So our job was kind of made easy in that sense. Still the notification actually clearly increased. The next slide, this is actually, we also need to understand, NTP managers also need to understand. You kind of see a trend where the notification get balanced out, and then the people, so if you have an ecosystem in the public and private with equal quality, the patients will start actually switching from public and private. So that you can clearly see from this slide. In the later, if you look at this thing, so there is a slightly private increase in this area, private notification actually increased, the public is getting balanced out. So this is a phenomenon, especially in a small geography, we should expect when you do equal kind of quality in public and private. So we got criticized, by the public sector saying you're cannibalizing us. But this is a phenomenon which we cannot actually control over it. Again, we track, the Gene Xpert utilization, because Gene Xpert was one of the services which we provided to the private sector. So, and also track the positivity. And you also see that there are some critical decisions we have taken based on this analysis. You can see a bump up in the March. So we started with a price that was around $8. for Gene Xpert. That was our initial place. But we actually had a period of free Gene Xpert during the March as a World TB Day offered to the doctors, that we saw that, okay, there is some praise factor here. So the doctors started actually increasingly prescribing during that free period. Then we had multiple rounds of free period and aggressive marketing. And we saw when the moment we had resources, enough resources and savings, we made it completely free and we saw bump up. And there are periods of, there are lull period also. We introduced free culture and DST beyond Gene Xpert, and we couldn't manage, then we withdraw that. And immediately that got reflected in their behavior. So this is something which when we deal with private, we have to have concrete clarity, what are the services you're going to offer, and you have to have a seamless system to offer it. And similarly, we also see that there is a trend of actually champion doctors 80-20 rule, not exactly 80-20, there is a trend actually being evolved. So when you want to focus on investment, this kind of analysis will help you. So who all are prescribing this, who all your champion doctors, work with them to maximize your investment. And also similarly, if you look at this thing, though the informal provider play a critical role, the number of notifications to the patient, the diagnosed is, becoming positive as TB is largely contributed by the formal doctors. And also similarly, the uptake of Gene Xpert. If you look at this, we started with, so though we had a bias in actually enrolling doctor, we enrolled the champion doctors. They had somewhere around 40% microbiological diagnosis. So, but over a period of time, that also improved. So the increase in microbiological diagnosis also improved. And to look at the provider behavior, we actually classified the provider, enrolled the provider into 4 quintiles based on the notification pattern. And we looked at the quintile, how the quintile changed. So if you look at these things, there are still 10 champion provider. I'm not getting into the details of the analysis, 10 champion provider, consistently giving notification. So again, to the NTP manager, if we have a control, if we have research constraint, we still can identify and work with the champions. So this is something important. And we also looked at how the lower quintile behaved. So the lower quintile means the first month of, the first quarter of enrollment, they were just notifying less number of patients. And how, with intense engagement with them, they also actually, there is a 25% bump in notification. This kind of analysis will help you actually in prioritizing, again focusing on. So how do we utilize this information? So we have done the microbiological analysis, we have done the notification analysis. We have to communicate back to the doctors. Okay, say, hi guys, you are standing here doing well, you are not doing well. So we actually designed a monthly reporting format, which is a PDF format, which we used to send to them and take the printout, but they were not actually carrying it. So we designed a WhatsApp message, which is actually mentioning, okay, doctor, award, you are having this many number of microbiological diagnosis, this many patients got cured, this many patients are on treatment, which actually made our work, made their work also easy. So we kind of like the message is that we have to engage with the private sector with the easiest method of communicating to them. And we also did a prescription audit to look at how their prescription behaviors are. So by and large, the prescriptions are actually 100% of the prescription had a tablet, INH, rifampicin, paracetamol, and ethambutol, which is good because with 4 drugs are there. Then 6% of the prescription had a second line drug. If you look at the lower these things, so fluoroquinolones were actually, and Moxie and Livovas are the add-on drugs they used to prescribe. So this gives us an opportunity to go back to them and actually ask them, advocate, don't do that. We use the peer and champion doctors to work with these doctors to change their behavior. So this is something which also I want to actually spend 45 seconds on this thing. How do we measure the coverage of it? So we know the provider got coverage. How much of the patient you're covering? So so we source data from the drug sales which is happening in the private sector. So if you look at that, this many number of patient months, so on an average, so this is roughly around 30,000, 25,000 patients are actually, that many number of courses of patient courses are actually sold in the private market. And where are we standing? So after doing all these things, so please just keep in mind, this is 24 watt data, our presence was intensely only in 15 watts. But still, this is a good measure to look at it. So we are only 50% recovering, 50% of the patients are still outside. So this brought in a new way to look at what is your denominator you're talking about. Most of the time when we run projects, we said 100% of the providers are covered, but that doesn't mean anything. So if you look at this thing, we are only 50% covering. So there are still 50% outside our cover. So what is the way forward? We are actually working in collaboration with the local government to have the complete data sets in the last 3-4 years and look at the hotspots. We know there are hotspots within Mumbai and have a different strategy. And as I mentioned earlier, we are also working with a mobile application which is Untitled. So doctors can actually see that patient full history, the adherence status, their microbiological confirmation status, their sputum conversion status, everything will be in a handheld device, which is a work in progress. By December, end of the December, which will be ready. Thank you so much.
Thank you, Shibu. So this was how in a city where most people prefer to go to the private healthcare for any need, not just TB, how this is being addressed and using a very good way of micro data kind of level of data for service providers. So now we move on to the last presentation.
Yes, and the last presentation is made by Vincent Meurens. He is different from most of us in the room, doesn't have a medical background but an economics background, and he is responsible for international relations at Riskscape, and he has a special interest in innovative solutions, including mapping and other technology to help solve problems in communities and locally. So the floor is yours.
Thank you. Thank you very much for the introduction. So I've seen many people struggling with the slides, so I'm going to hope I'm doing this right.
Yeah,
so,
still the former one. So
yes.
yeah, no, but it seems to work if you.
Can we have the presentation, next presentation?
Can you click forward? Yeah, okay, there.
Okay. There? Okay.
Yeah.
Okay. Well, thank you for giving us the floor here, and welcome everybody. As you've heard, I'm different than most of you, but we do have an exciting story to bring. Maybe just a few words on Riskscape. So we got an assignment about almost a year ago, I think, from the WITS Health Consortium in Africa. To look at the tuberculosis impact on a particular mining community. So looking at migrant workers across the region. So we didn't actually look at South Africa itself, but we looked at Southern Africa as a whole. And we used traditional GIS and statistical methods to come to an overview of what is happening in the region and where we might be focusing in the future. So Riskscape itself is a company, it's a technology company that has consolidated a number of fields, mainly within big data analysis, GIS and spatial technology, but also looking at artificial intelligence, machine learning, and those kind of concepts to basically form solutions and platforms and methods for this kind of projects. So, let's see. Okay, so the scope of work that we were assigned to was basically to look at a database, creating a geographical database of the mines across Southern Africa. Besides that, we looked at the population density across the full region. We looked at the mine workers, the present mine workers, and the ex-mine workers, so their present location, but also their location of origin, because they do go back at a certain point. We looked at the determination of TB hotspots within the area. There are already hotspots existing, but we were especially interested in potential future hotspots in the region based upon the migration of those mine workers. We did desktop mapping of healthcare facilities throughout the region. We also did field work, so we visited a number of those healthcare facilities in the hotspots mainly. And then we did an advanced routing analysis across the region to look at potential routes that might have a higher incidence rates going forward. And then at the end, we basically came up with a report and also a portal where you can assess all that information, look at the maps and drill down into the various levels of information. So to start with, as a first, we looked at the complete Southern Africa. So there were 10 countries in total that we covered. So we used traditional GIS methods. So we looked at satellite information, we looked at settlement data and so forth to come to a complete overview of the various regions and admin boundaries. Then we looked more in detail to census information. So we looked at, okay, what are the mostly densely populated areas within the region? And we also looked at the mines. Where are the mines located throughout Southern Africa? Because that's where most of the migrant workers are active. So we brought all that together in a regional map, and that was the basis of the full study going forward. So if then we looked at the geocoding of the mine workers, then you could see that we had a mine worker heat map, so you could see what is the biggest concentration across the region of the mine workers itself. And then to really pinpoint them to a very local administrative level, we created also a point density map, where then you could see, okay, where are the selected healthcare facilities, what are the TEBA, so TEBA was basically a source that we used of mine workers. It's a recruitment agency, social services agency across Southern Africa for all those mine workers. And so we located all of those across the region. And all of that formed a basis to create a Thiessen polygon. So Thiessen polygons are basically, we went away from the traditional admin boundaries. So we basically created Thiessen polygons to allow us, even within big urban areas, to identify the highly densely populated areas, and then also map the mine workers to that area. So you could really pinpoint the locations where we had to further drill down and do further study within the field. So this is the basis of the full study. So that's how our maps looked like then. So the statistical methods that we used, before the start of the project, we did some research, obviously, and maybe there's people in the room that might think different, but we did not find any uniform model to look at the spread of TB across regions. So that was one that we sort of realized. So our approach relied on the process of geocoded data, and we looked at the mine workers and the ex-mine workers, and then also the general population density and those Thiessen polygons, and then we allocated the two to each other. So then you could assume that where you have a highly densely populated area with a high density of mine workers, and then adding on top of that the incidence rates of TB, that you do have a potential risk factor. And that's what we used also to really start drilling down and identifying the areas where we did field surveying across the region. So an example of Lesotho, so this is what it looked like. So you could see that, okay, you have the country boundaries, then you have these historical focus areas. So we did talk to a lot of communities, to local organizations, healthcare facilities and so forth, and there are obviously historical focus areas. We identified new hotspots and focus areas throughout the region, and then we started identifying healthcare facilities within those areas itself. And then we went into the field. So then you basically got a list of all the healthcare facilities within the region. Our people had a questionnaire, and so they were trained with that. So they basically also had technology. They used mobile phones. So we also geolocated everything. And then we started looking at, okay, what is the number of cases treated? What is the amount of healthcare workers that they have available? What are the type of facilities and so forth? And that information will later on help us to also identify where there is room for scale up. So what healthcare facilities need to be improved based upon those hotspot areas or the potential future hotspot areas. So that's an example of Lesotho here. Now, important in this whole story, if you look at the migration of the mine workers, is that traditionally one would look at the mines that they are active or the regions that they are living in today, and then let's say the labor sending areas, so their origin, where did they come from? Now what we did, we are a company that is specialized in geographical data but also mapping and so forth, so we used cellular data and GPS tracks to identify the most common routes amongst those labor sending areas and the destination. So we did not have a traditional straight line approach, so we basically looked at what are the most important routes used, and like that we could identify basically corridors by which you could provide services, training, education or healthcare. So for the Southern African region, it looked like that. So you basically had the mine worker origins, so the labor sending areas. Yeah? You can see that in the legend on the right. And then you had the mine worker corridor. So if you would drill down into this map, and it's available online, so we can show you that later on. But if you would drill down in this map, you could see that if you go in the remote areas, obviously, such a route has little importance. But as they start coming together, the routes really become very important. And you might have up to 100,000 people traveling to a particular corridor route, which makes it then indeed a relevant instrument to start educating people or looking or identifying potential future hotspots. So I think this was a very important exercise in the full project. Now, going forward, so as explained, so everything is available on a portal, so you can drill down and you can select the various layers and look at the various areas, what information is available, what are the healthcare facilities, what services do they provide, and so forth, what are future potential hotspots, so all of that is available. We do believe that there is a need, obviously, to go further and look into those settlements and also keep the healthcare facility information up to date. So in total, we visited about 50 healthcare facilities throughout the region. So we really had to prioritize on those hotspot areas, educate the people, and then go into the field. There were some issues across the region. Ethical clearance was one. So not everybody was willing to collaborate with us and was willing to provide the information. But after a lot of effort and clearance from National Health, etc., we didn't manage to get and collect sufficient data. So we do think there is further need to continue collecting that information throughout the region, moving further from those hotspots. We believe that there is a potential to register and geolocate TB patients through the use of cellular phones. So the solution as such is not intended to identify the individual patient and find his location, but if you look at it at a broader scale, you can really identify where most potential risks are available, if you map that then to population density and so forth. So we do believe that there is an opportunity there, and it also allows you, for compensation and benefits, healthcare services and so forth, to communicate with them. So we do believe that there is a high potential on that side. Then there is obviously cluster analysis of current and new TB patients going forward, and then monitor the hotspot developments. So the hotspots that are identified today, is that indeed being realized in the future? I think that is important to auto-correct the system. So the model itself that we applied, so we have, as said, we are a technology company, so we have developed a number of sets and tools that can be applied in various models. So we have created a pandemic control framework by which we can look at much broader exercises. But in general, so what we used here are three main components, and we can use that across various diseases. So there's number one, which was the data collection. So we collected all the information, we threw it into the spatial database model that we have available. Then we generated the T-SIM polygons and started identifying the areas where we need to focus. So it's much more granular than traditional administrative boundaries or on country level. And then obviously we have the analytical solution that allows you to drill down in all the data and identify what is needed going forward, or where you need to go into the field to collect further information. So these are the major components, and that can be used for many other diseases going forward as well. So the health sector relevance, obviously, well, I don't think we don't need to spend too much time on that. On a regional level, of course, we collaborated with WITS and with teams in South Africa. So there, it's definitely very important on a regional level to look at the TB baseline and the geo database, so to provide that information, keep it up to date, and further enhance it, that portal. Then identify the TB hotspot areas and the development, the way they develop going forward. The TB affected communities, target list for healthcare scale-up, so based on the information that we gave and the opportunity there is to increase that, so look further in that, and then obviously further enhance the portal for various stakeholders throughout the region. On a global level, we think it's important to look at the cross-border travel corridors. So what we've done in Southern Africa, obviously, can go much further. And we've seen the example in Vietnam as well, where in the south, there is a belief that potentially towards Laos and Cambodia, that there is some migrant workers there. So that is something that is important to look at. then it's fast turnkey approach, so it can be implemented fairly quickly, and it can be applied for HIV, Ebola, Congo fever, and others. And there is then the track and trace potential going forward based on mobile technologies towards the TB patients in general. So this is, I think, what I had to bring. So thank you very much for your attention. Yeah.
Thank you. Thank you also for your very nice presentation and a slightly different angle again, but also a very nice example of how different types of data can be used. We have 10 minutes for questions, which is not a lot, but thank you all the presenters for trying to and keeping basically to time, but we had many presentations. Can we, if anyone wants to speak and has a question, please raise your hand. Do we have, is there a microphone somewhere? Anyone has a question, please be brief. And also explain to whom your question is, and identify yourself, that would be nice.
Take this.
Thank you. My question is to Vincent from Riscape, and I'm Chulani Mbata from IRT. I work in South Africa, and we're one of the sub-recipients from TIMS. And the question is, I think it's great to see how well you've shown in terms of the power of using GIS mapping in areas where you already have the data, like like in the mining sector where we know where they're based and we know where the mine workers come from. For example, TEBA can provide that data. We have a clear indication of the origins of the miners. But how can we use such a very powerful, useful tool in terms of areas where mine workers are very mobile and work in informal settings, such as today you screen a mine worker and the next day he hears from a friend in another district that, you know, there's another mine or gold being discovered, and he moves before you even put him on treatment. So if you can just help us understand how we could utilize this tool in a very dynamic way, as opposed to in areas where we already know that the mines are there and the people we know they come from.
Yeah. Keep it short.
Any other? We will take some questions and then we'll respond.
Thank you very much. I'm Osman from Kenya. My question goes to Dr. Massini, also from the same country. First of all, Dr. Massini, thank you for the very elaborative presentation. I think it was very educative. My question is, you alluded to the fact that there is a variation in notification between counties, and I think one will guess that one of the reasons for this could be the variation or heterogeneity between the TB programs, even between the counties. So, as opposed to the actual burden in terms of differences between the counties. So one of the ways which I'll think about validating that is looking at a standard method that has been used to look at whether the burden between the counties is similar is the prevalence survey, which was conducted recently. So my question is, how does the heterogeneity between counties compare in the notification versus the prevalence survey? So does it mirror the same, or, yeah, that's my question. Thank you.
We will take one more question and then the panelists can reply.
Thank you very much, Sahum. David Mamija with the National TB Program in South Africa, and let me just start by a small advert. The Riscape wonderful mapping that was presented is actually coming out of what I consider a good partnership of 10 countries in the Southern African region, which funded the work. And I think it's a demonstration of how well countries can do when they work together, obviously with support from the Global Fund. That's just an advert. Now, you know, we do these hotspots identification through mapping, as demonstrated by that particular presentation, as well as the one from Kenya. Now, I think identifying a hotspot does not necessarily mean that your TB burden in that particular area it's higher than, you know, in other geographic areas in that particular country or region. It might actually be a reflection of a good case finding interventions, and where maybe you have a low burden and therefore you don't identify that particular area as a hotspot. It could be a reflection of weaknesses in case finding interventions. So my question is, when these hotspots are being identified, how much do we factor this issue which I've just raised about effective case-finding interventions and non-effective case-finding interventions? Thank you.
Thank you. I would suggest this one goes to Vietnam, the hotspot question, right? But let's start with.
Thank you. I hope I still remember the question. Actually, I don't. No, joking. Yeah. Yeah. If they do not err. Yeah. So it's a very valid point. So it may be important to know is that in South Africa, indeed, there is this organization TEBA that covers mine workers. So they have a database of around 230,000 mine workers across the region. So we were able to geolocate all of them and then identify their origins as well. Now, if you don't have that available, then it becomes more challenging. And obviously, looking at the mines in some of the surrounding countries, we didn't have that information available. So then we approached, so there was first of all the research that we did on the various mines across the region, and then we did interviews with those. And then we talked to local communities and governments to identify those, and also local, let's say, organizations supporting those mines within those countries. But there's a lot of field work and desk work that goes into that, definitely. What I think is important is that you give something back. So whomever you're trying to collect data from, I think it's important that you have to try to find a way in which you can give something back that they also benefit from the solution going forward. And even if you look at a TB patient, if you would like to have him communicate and connect to you through a mobile phone going forward, you need to be able to give them some kind of information back. So that can be indeed helping them on their compensation plans, that can be healthcare related issues and so forth. So I think everybody benefits from that, and that might help in the future to keep track of where mine workers are moving to. So that is what we believe. So it's really community based and trying to, give something in return.
Thank you. Julian wants to add, just very briefly. Julian is from the TIMS project in Southern Africa.
Thank you, Dr. So I'll be very brief. I think the TIMS project was really fortunate to have a very rich data set. So the TEBA data, there was a significant amount of information that came through from there, but we also did overlay the MBOD, which is the Medical Bureau of Occupational Diseases, a database of about 500,000 ex-mine workers on top of that. So we're able to geocode a large number of mine workers and ex-mine workers. I think the next steps with the TIMS project is how do you integrate this now into our cross-border referral system, which will address, I think, David and Tulani, your questions on how are we able to track people as they move between borders.
Thank you. Now the next Kenya question.
Thank you. I think the question was how the prevalence survey, how the notification data by county would compare to the prevalence survey results. I wish I had that, because the problem is that prevalence survey is not, TB prevalence surveys are not usually powered to provide data for subnational level. for the simple reason TB is still fairly a rare disease. You would require actually a very huge sample size to be able to get enough power to provide estimates for subnational level. So we don't have.
But you do have some, in most prevalence surveys, you have some urban, rural kind of thing. It may not be powered to give you very precise estimate, but that can give some idea about the burden distribution. Yeah. So now the third question is the hotspot question of David and Dr. Ho.
Yeah, thank you for the question. This is for the analysis and for the results of the notification data, and also for prevalence survey. We identify some hotspot area in the country, and this is the as you mentioned, is not only this is the burden of TB. Not only one thing is the TB, the burden of TB in this area is high, but also is may reflect. This is the case finding in this area is better than the other. So this is for the analysis. Is we try to answer the question. This is how reality of the case notification is reflect the true burden of the epidemiology in the east area. So identify the hotspots and finding the intervention suitable. It's even for hotspot and for the where is a low notification. For the low notification, this is we have identified this is who is a missing case, and for hotspot, this is we have to identify the intervention suitable to reduction the TB cases in the hotspot area. So I think this is the purpose of the analysis, to identify the hotspot, to put the suitable intervention, which factor make the area is become the hotspot, and which intervention is suitable. Will be different between the area and area.
Thank you. I know that you have many questions and comments, but I would encourage you to catch them during the coffee break or while they are here. We have completely run out of time, but let me just quickly conclude by saying a few things. This is an area that the TB community has been struggling with. How do you find the people that are missing from care? And I think this whole session was devoted to how do you get the data to act. And I think that we need to remember. Just to summarize how we started with Miriam, the match approach, and 3 countries, Bangladesh, Vietnam, Kenya, also the private sector experience in a mega city like Mumbai, and very interesting, the last one, how do you use different techniques for key population groups. And very interesting, the last one comes from a completely different background, not health, not TB, but GIS. And I understand that you belong to the TomTom group. When I drive car, I use TomTom as a navigation device, and I think that kind of different skill set we need to bring into the fight against TB to be able to get some things that we are not getting. And I think you also mentioned artificial intelligence. That's the future, I think. So thank you all. Hope this was useful, and if you want any information, if you want to get in touch with the people who presented, please approach us, me, Miriam or Lucy. We will be very happy to put you across. Thank you.